And thank you for the sharing the opportunity. I'm Amna, and I'll be presenting on the COVID-19 situation in Yemen and MSF experiences in the context. Can we quickly the slides, please? Thank you. The one before. Yeah. After 6 years of intractable war, the country of Yemen is currently divided into a southern and a northern part. The conflict has taken a heavy toll on the already vulnerable population, and currently 2/3 of the 30 million Yemeni people are in the need of humanitarian assistance. In face of existing poverty, forced population displacements, food insecurity, disease outbreaks, and a very fragile healthcare infrastructure, Yemen remains ill-equipped to handle the added burden of the COVID-19 pandemic. It has been over a year since the first confirmed COVID-19 case was reported in the country back in April 2020. It was anticipated that the country will face a high number of cases and deaths. To date, the data on COVID-19 surveillance indicators, including PCR testing across the country, is limited and not publicly available from all sites. From the north, only 4 confirmed cases and 1 death were reported in Sana'a back in April 2020. And from the south, publicly available data is restricted to 4 out of the 7 public health laboratories with PCR testing capacity. These 4 labs are situated in the governorates of Hadramaut, Aden, and Taiz, and accordingly, these are the 3 governorates with the highest case notification in Yemen. Yemen ranks at the bottom of PCR testing capacity with 2,387 tests done per million population, second only to DRC. As of 31st May 2021, 6,742 confirmed cases and 1,321 associated deaths have been reported from the 11 southern governorates. The map on the right shows the epidemic curve, highlighting 2 waves so far. The number of cases reported in the second wave during the first 5 months of 2021 is more than twice of that observed in the first wave in 2020. The naive case fatality risk of 19.6% is globally one of the highest recorded. However, it can largely be attributed to the limited PCR testing, which was spared for the patients presenting to healthcare facilities with severe or critical symptoms. This observation is further supported by the decrease in CFR observed in 2021 in relation with increase in testing and data availability. MSF teams have been actively engaged in COVID-19 response across the country, and here I'll be presenting information from the MSF Projects by Operational Center Paris. These include 5 different projects, which are 3 inpatient facilities in Sana'a and Aden, and 2 isolation, screening, and referral facilities in the northern governorates of Sada and Amran. The epidemic curve on the right shows the weekly trends of admission in the MSF northern and southern sites, and against the backdrop of the nationally reported cases. And you'll notice that in the south, the MSF admissions peaked way ahead of the national curve during the first wave. In contrast, in the north, you see that the admission trends run in parallel with the epidemic curve from the south during the first wave and beginning of the second wave. And currently, our projects continue to report a high number of admissions despite the decrease in cases seen in the south. So overall, 2,138 patients were admitted in the 5 facilities, and due to limited access to testing, only 39% of these have PCR results available, and overall 8.3% were reported as confirmed cases. 70% of these patients were men with a male-to-female ratio of 2.4, and the median age of these patients were 55 years. More than 40% of the hospitalized patients reported at least one coexisting condition, with the most frequently reported ones being cardiovascular diseases, diabetes, and chronic lung disease. Out of the 2,138 patients, 1,022 patients were discharged, 185 left against medical advice, and 129 were transferred to other facilities. The overall facility-based mortality is 30%, but it varies greatly between the sites based on admission criteria. The admission criteria focus primarily on the patients presenting with severe to critical symptoms in need of oxygen support. The three curves here show the clinical outcomes and relation characteristics like age groups, gender, and presence or absence of coexisting conditions. And a higher proportion of deaths was recorded in older patients who were aged over 40 years, patients with coexisting conditions, and male patients. Based on these observations and experiences, I conclude that COVID-19 impact in Yemen is vastly underestimated. The data on testing and patient characteristics is limited. Surveillance data has improved during the second wave in 2021 due to the enhanced PCR testing and data availability. Observations from the MSF sites improve our understanding of the epidemic trends in both northern and the southern parts of Yemen. MSF projects recorded a high mortality among patients, even in the younger age groups. Future COVID-19 surges cannot be excluded in the backdrop of insufficient public awareness, poorly implemented mitigation measures when and if any, limited vaccination, both on accounts of low availability and low vaccine confidence, and the continuous population displacement. Thank you very much for your attention, and I would like to end by thanking my colleagues in MSF and Epicent who supported me in this project.